So in some ways, we're coming full circle. We started out the morning with this great group of survivors, this great group of advocates that had the opportunity to tell their story, to share their experiences, to talk about what went well, and quite frankly, what didn't during the process of their care. So now it's sort of their turn. And what I'd like to do in the next 30 minutes is really just ask each of these individuals, it's sort of a call to action. It's your turn to tell the audience. And what I'd like you to do is tell the audience what can be done and what do you want to see the oncology community begin acting on today after everything that you've heard. Please.
Personally, what I would like to see happen is a greater focus on physician education. I'm a big proponent of clinical trials and making sure that they're available to all people, whether you get treated at an academic cancer center or in the community. And what I have learned over so many years is that many people, I hear often, minorities don't get involved in clinical trials. So, we have a low representation of minorities in these trials that we have. And what I'm finding is that they're never asked. So about 3 years ago, I was at a conference here in Washington, D.C., where we have 4 cancer centers. And there were 100 plus African-American breast cancer survivors assembled who live in this area. And someone said, how many people have been involved in a clinical trial? 6 people raised their hands. Then the question was, how many people have been asked to participate in a clinical trial? 6 people raised their hands. So when asked, people say yes. But the problem is they're never asked. So I would like to see more focus on the physician's part of that, communication, making people aware of clinical trials and what's involved. That's something I think we can deal with right now.
So do you think, though, that it extends beyond the physician? What are the other opportunities? Because I don't think we can put everything on the physician's back.
Okay, good point. Well, I heard earlier today about, in talking about health disparities, yes, there should be a focus on the social determinants of health. We do that now, but I did not hear anything on the physician. So I think that patients need to be educated about what clinical trials are available. Earlier, I spoke about making the clinical trials available in the community setting, where people tend to go for services where they feel like a person versus a number. So I think that we could encourage those funding mechanisms to encourage the collaboration between the large academic centers and, say, a community oncologist to help with enrollment. The other problem I've learned about is, or challenge I'll put, is maybe with the marketing materials about clinical trials, I gave someone some feedback on the materials and suggested that they use the common name of a particular drug, and I was told the IRB won't allow that. But if I'm a patient and I recognize a drug, I'm more apt to say yes, but if it's a drug, if it's the name of a drug that I'm familiar with, I may say, I don't know if I want to participate in a trial with an experimental drug. Something very similar, simple as that can prevent people from participating. It's a barrier that we don't acknowledge sometimes. So,
Stephanie, what would you like everyone in this audience to work on?
Oh my goodness, I wish I knew. It's overwhelming. Just listening to everyone is incredibly overwhelming because the issue is so broad, and yet within all those issues of that breadth, they are all incredibly complex. So I guess the piece for me is to make this manageable, find ways to make this huge task manageable so that headway can be made. Because I can tell you, I've got a lot of fears right now. I mean, I'm doing well medically, but I don't know how long that will last. I'm not working, so I may not have insurance when my COBRA finishes before Medicare kicks in. I have been on 2 clinical trials, but I don't know. I do actually know what drug will be next, but I don't know that there's one after that because there are so limited options in lung cancer. So, you know, you are all such brilliant people and bring so much to the table. And so I guess I'm asking that you make this job manageable so that these things can be broken down into all the things that have been discussed and headway actually made, because lots of time there's talk without feeling like we get anywhere. And it is really scary. And even just the discussion about value, I mean, I may be one that's not of value. I mean, first of all, I got a disease that everybody thinks I asked for, even though I had no risk factors. And I'm sure that I've spent probably over $2 million in 10 years. My prescriptions are $15,000 a month. And I'm incredibly grateful for that. And my children, I don't care about me. I mean, I would be happy to go today, not happy, but I would be willing to go today. I'd be at peace to go today. But not with a 12-year-old and a 14-year-old out there needing me and expecting me. I have a responsibility to them. And I feel like I was entrusted with them for a reason. And so, you know, it's easy for me to say it's worth the money, and maybe it isn't to others, but, you know, there are a lot of families out there that feel that way about their loved ones. So it's not as selfish as some in society might think. It's really to fulfill our responsibility here. So I'm asking you to basically make the problem manageable so that it can be, you know, fought.
So what I hear you saying is that you, your life, and your family are more than a quality. You may not fit into a pathway. You may not necessarily be able to calculate your worth through a drug abacus or an evidence block. You're a human being who has a life and who has a family, and you're a human being that's alive and thriving,
Yeah.
and that's value.
Absolutely. And a responsibility. That for me is the piece.
Yes.
I have a responsibility.
Yes. So our one-man band there, now I'm counting on you with all of your expertise and your passion to tell this audience what to do.
Okay. So today we heard a lot of discussion about value frameworks. It's a term you're going to hear more often. I think it's kind of emerged over the last few years. But these are basically, you know, decision support guidelines, and it really means it's helping a physician make decisions. It shouldn't be a Bible. It shouldn't be a rigidly defined clinical pathway that says this is the way this particular patient needs to be treated. What I would caution everyone here to look at when you see these value frameworks, very much like reading an abstract. Who wrote it? Who were the people behind this? Who were the principal investigators? You know, who are the practicing physicians? So I think it's very important that we really need to vet, at this point, these major value frameworks that are coming out. I like what NCCN is doing, what ASCO is doing. I think Memorial Sloan Kettering has done a pretty good job with their limited number of recommendations through their Abacus program. But again, I think this is something we need to be careful about. Now, I'm a big proponent of clinical trials, and I participated in my blood cancer, participated about 8 clinical trials, and in the metastatic prostate cancer, probably 3 or 4. And I want to tell you the way I have survived this, and I'm not sure this is going to work for everybody, but I cheated every step of the way. And the way I cheated was I wanted to know every biomarker that was going to be relevant. And it was sort of like, I don't come from medicine or life sciences, but I really wanted to learn about these biomarkers and what do they indicate, and when am I responding to a particular therapy, or when am I refractory to a therapy. So I tracked as many of these biomarkers that I could get my hands on. In blood cancer, it was relatively easy because we had good blood chemistry reports. And so by tracking the biomarkers, I could tell during a clinical trial whether I was responding or refractory to a drug. And when the biomarkers indicated there really wasn't a response, it was time to move on to something different. Now, a normal principal investigator doesn't like that approach. You want to stick with research right to the end. But I was more interested in the care outcome of this. I'll make it clear to everybody, I don't participate in clinical trials for any altruistic reason. I want to survive. If I can survive, there's a whole bunch of good things I can do. But anyway, I think, and one final point, we're now in a very difficult time politically, and a lot of us are going to spend some time on Capitol Hill in the very near future trying to convince lawmakers. And coming from the sales profession, I just want to say one thing. Remember that this has to be a nonpartisan effort, and we want to sell. We don't want to go over and beat up anybody. We want to try to convince people of the real important need for rational funding of biomedical research. And I think that's something that we hopefully will come away with today, is that it's a nonpartisan issue. It's something that benefits all of us. But we have some serious selling to do. This happens anytime a new administration comes in. So let's all sell real hard. Thank you.
Okay. Wendy?
I have 3 overlapping suggestions. One is to talk about what we value all day, every day, wherever we are, be it at the lunch table, at morning rounds, at group meetings about patients, at the bleachers of baseball games. Talk about what we value. In particular, talk about the value of the doctor-patient relationship and giving the doctor time to learn about the patient as a unique individual, giving the doctor and the patient time together to have a dialogue. And in support of that, helping doctors optimize that time. I think a doctor should not be spending 1 second explaining to a patient what staging is. All of that education can be done by other people so that the doctor talks with the patient about the things that matter in terms of decision making and care that only the doctor can talk about. The second thing is, it seems like all day we've heard the same theme about patient-centered care, put the patient at the center. If we're going to do that, let's give the patient a stronger voice. Let's do everything we can to educate the patient so the patient can know what's going on and advocate for him or herself. You talk about educating the doctors to ask about clinical trials. At one of the cancer centers in Dallas, every patient who goes to the bathroom and shuts the door is going to see a sign that says, "Have you asked your doctor about clinical trials?" So there are a lot of opportunities to educate patients, be it in the doctor's office or the bathroom. And the other thing about giving the patient voice, I'm 62 years old. I remember the days that mothers wanted nice, warm birthing rooms. And the medical community was not particularly excited about this, but patients demanded it, and it happened. And we've seen that. I also was diagnosed when I was a cancer victim, and the National Coalition for Cancer Survivorship pushed for this term survivor that nowadays is, just a normal part of our lexicon. Patients can be the voice for patient-centered care. And the last one is, we talked a lot about listening to what patients value so that we can respect what they value and design their care to respect their values. And the little excerpt read from Dr. Kalanithi's book, When Breath Becomes Air, I think one of the points he was making was that sometimes patients don't know what they value at that moment. And it was a beautiful section of the book where the oncologist carried Dr. Kalanithi when he couldn't advocate for himself. She carried his hope of doing surgery again when it was still a possibility, when he couldn't even imagine it, when he didn't even have the hope for that. And again, that only happens when there is time for developing the doctor-patient relationship and supporting these dialogues that help us do the art of medicine.
Beautifully put, thank you. So Rick, I have the pleasure and the honor of knowing you more than anyone else on this panel.
And the pleasure is mine also.
Knowing your cancer experience, also knowing that for 20 years you have seen thousands of clients. You've heard thousands of stories, witnessed thousands of struggles. Rick Dickens, now is your chance. Please tell this audience what it is that you want to see.
Well, thanks to Trish, forgive me, I'm losing my voice again. Thanks to Trish, I actually figured out in 20 years on our Hope Line and such, I've probably spoken to somewhere upwards of 30,000 patients, caregivers, bereaved professionals in the course of that. First of all, I want to say this was an amazing conference, I thought, and it was really very, very rich. And although I came in here with some ideas, they've definitely evolved leading up to this conference when we had a telephone conference for us to decide what we were going to talk about. I'm going to start out, though, what I love, and my colleague, mentor, and supervisor, Ellen Sonnet, who's sitting over there, has started to use more and more. I don't know if she's aware of it. She says, if you've spoken to one cancer patient, you've spoken to one cancer patient. And I just love that, because what we're hearing too, we're all different. I love the fact in all of these panels is that we've had some really all medically based, but different disciplines looking at how research, how analytics, how oncology, how clinical trials, how all those things could be geared to bring the patient more into it. And they're doing what they can to get the patient perspective. But you've got all of these different silos to some degree, and we're talking about a disease for some people that are maybe 6 months or so, but for many goes on for years. So value itself means many different things to the patient and to the providers throughout that time. But what I was most moved by today, I think, and some of the speakers, was Dr. Schwartzberg has said patient satisfaction is what he was talking about at one point. And that's very important, but one has to look at when does that satisfaction start? And if it doesn't start in the beginning, are you trying to get the client, patient, satisfied again, or helping them to become satisfied after they've already been angered and dissatisfied? Sanjay, who was just up here, had talked about the currency of value as time and quality of time, and definitely that's already what's been spoken about, and I really like that. I didn't get her name. I've got it wrong. I thought it was Clara. It's something else in one of the panels, and she thought, well, I'm going to save that one for last, because Joan London did say when she was talking about density in breasts, and I don't have it exactly right, but what she did say within that context and about the need to know is, she said sometimes often it is confusing at first and downright misleading. The confusion itself has to do a lot with how we integrate it. But the truth is, a lot of times perhaps it is misleading, or it's perceived as misleading when information is shared that a patient is desperate to cling on to and doesn't hear this is what we hope for. So finally it was, again, I can't remember her name, but she had said in one of the earlier panels, the value in insurance and the impact on family. And I started this earlier today. I wasn't going to talk about value from this perspective, but I began to go back as we've been all re-examining our own cancer's experience and thinking about the profound differences between my first, when I was working for a big film company, corporate company, and had in 1991 massage and everything, no paperwork, nothing. It was all taken care of. And my recurrence 3 years later when I was in graduate school and had gotten a conversion policy that was very expensive, and I just thought I needed it, knowing I would have a recurrence and that I had a trajectory of probably 10 years to live, but it would, much the same as the route later that Wendy took, and rituximab wasn't there at that time. But as I'm sitting here, I'm going, we all have to do what we can to bring value definitely to the individuals that we work with. And there needs to be some kind of continuum, and hopefully there's going to be something congruent in that. But I do think, and I hear all the time, it might start when the doctor tells somebody they have cancer. But it doesn't go any further until the person figures out, how am I going to pay for this? Where am I going to get the treatment? What's going on? And that's all the provider, or not the provider, the insurance carriers that they have, or the Medicaid, Medicare, or what's going to be out there. And I hear from people over and over, too, in the midst of all of this other stuff. They're going, well, how much is it going to cost? We've mentioned, is my child going to have to drop out of college? And we just mentioned all of those things. Where do I even get this treatment? Where could I get inpatient treatment in my plan and stuff like that? It is so complicated. It is so complicated. So patients start out, and family members, almost from the get-go, you've got cancer. And in their head, they go home that day, not remembering a lot of the very specifics about where we're moving with this, but how are we going to deal with this? And if you go to your insurance carriers, I had to with my conversion policy at a time that I was in graduate school and living on a shoestring myself, going to graduate school full-time to become a social worker. I had that conversion policy and actually had to find money to pay for a insurance lawyer who was a social worker and a lawyer, who charged me a substantial amount to read it. A great guy, he really was. Came to the end then and said, I could tell you what your policy says. I can't tell you what it's going to actually cover. So it's kind of like, what's the next step? And if there isn't value in the beginning, and value to me then says, there has to be trust. There has to be understanding. If one uses an analogy, if you go to buy a car, and it doesn't mean that we all have to get the best product or the same level of care, but if you've got the money, you go out and you buy a Mercedes-Benz, or you buy a Lincoln, or you buy something. If you don't have the money, you still go out and buy a car, and you buy a Toyota or something like that. They don't just sell you the car and then give you the keys and say, okay, figure out what you're going to do, and God bless. Hopefully it's not going to break down anytime. There's somebody you go back to. There's integrity. The person who's providing that is going to help you through the process when a problem arises. And more, when I talk on our phone and I talk to people about empowering them and about, it's always the doctor's making me do this and the doctor's making me do that. If I could engage them, throwing in a little humor, sometimes I'll say, I've been doing this for 20 years. I've never heard of the chemo police. I've never heard somebody coming into a house and pulling you out to go and get that radiation. But there is this kind of, not victimization, there is this kind of, and depending on where people are in the life stage, there is this kind of, the way they their perception of medicine and the hierarchy of medical teams is that they feel they do have to do that, and the pressure of the family, is they're a loser if they don't. But what I'm going to just say, as I'm walking away from this conference, we all have a role to play. But if we're not playing it together, then this person is giving good value, and this person is ignoring the patient. And they're going along the line, and they're getting more and more mixed up, more and more angry. And the ones who are passing the messengers are the ones who are going to get beat up on.
Thank you very much. Now, my job is moderator, but for those that know me, I'm not shy. I just have to, in 30 seconds, add my 2 cents. We've heard a lot of diverse information today from different constituencies. We also, the inspiration of Kathy and what she's doing at Harvard with the Kraft Foundation. What I would say is that if we don't come together, if we stop pointing fingers, come together to solve this issue as a community of advocacy, a community of industry, a community of providers, we will be on a far better path than where we are now. So my challenge to you is let's be inclusive and come together and solve this issue. Thank you very much, and thank you to my wonderful panelists.